Hello, welcome back to the Black Doctors Podcast. I am Steven, your host. This week, we're going to jump back into the second half of a conversation we started last week with Dr. Anthony Douglas. He is a general surgery resident. He's currently at the University of Chicago Medical Center, and I want to make it clear that the opinions expressed in this interview are our own. They're not representative of our employers. Before we jump into the rest of that conversation, I want to talk about two things that happened recently in social media. One was social media and real life. One was a horrifying story about an obstetrician and a very complicated delivery with a very, very terrible outcome. Such a horrible story. It was difficult to read. Essentially, there was a shoulder dystocia, which if you worked in labor delivery, if you're a medical student rotating through the service, if you're an anesthesiologist, if you're in any way, if you're a pediatrician, if you're involved in working on labor and delivery, you know the significance of a shoulder dystocia where a baby gets stuck during delivery. And the story is so horrifying. The baby was stuck, was not coming out, eventually going back for cesarean delivery. The baby did not make it through the procedure. The baby was horribly disfigured, mutilated during the process, and the family was received some mistruths, and the family felt the hospital system was not completely honest and straightforward during this experience, and not surprisingly, is resulting in a lawsuit. The information that gets released, I just want to say it's so tough to really figure out what's going on in these cases. Number one, there's the media, there's the headlines, there's the viral content where if you describe things a certain way, you're going to get a lot of clicks, you're going to get a lot of views. That is a given. Number two, you have a family that has experienced a devastating loss and they absolutely deserve, they can never truly be made whole, but they have the judicial system at their disposal and they should use it appropriately so. You have, on the other hand, these clinicians, this obstetrician, the labor and delivery nurses, the anesthesiologist that was involved. You have folks that, didn't come to work expecting to have a horrible outcome for their patient. Nobody in healthcare expects these things to happen. It's not intentional, obviously. It's an accident. Accidents happen. Bad things happen. Patients have bad outcomes, unfortunately. It's the nature of the business that we're in. And it is so easy to Monday morning quarterback. And it's insane that we're Monday morning quarterbacking based upon a viral caption from the shade room, right? You see these things, you're like, oh my God, how could this happen? And it's stuff happens, unfortunately. And there's always more to the story. As physicians, as healthcare systems, we are extremely limited in the things that we can say about these situations. So we're not getting the full story. All we're hearing is one side of the issue. A very similarly horrifying story was recently released. This was out of a hospital in California where a young woman had surgery, kind of a cancer reconstructive surgery, the end of a long, devastating course of cancer that she'd survived. And she unfortunately had a complication in the recovery room. And yet again, the information that was released in the media, although this time it was, I read the story with my own eyes. I looked at one of the pieces of documentation, which was kind of a printout. It looked like from an Epic electronic healthcare records that kind of talked about when the intubation occurred and some of the complications. And, being an anesthesiologist, it's easy to kind of break down like, okay, the patient experienced likely respiratory arrest, possibly laryngospasm. The patient was intubated. There was an arrest. There was other measures such as a transesophageal echo probe being placed. It was noted that the patient was no longer intubated and had to be reintubated. And it's just incredible, like when you put this story up and what people see, what people say on Twitter, like, oh, well, how do they not recognize the intubation? How come there wasn't any end-tidal CO2 monitoring? How come there wasn't this or wasn't that? And again, it is so easy to sit back in the comfort of our homes and judge these physicians, these healthcare providers, these nurses, and list the things that they could have or should have done. And I think, of all times now when burnout is so real and so present, we do need to extend that grace to people and understand that we don't have all of the details, and have some faith and trust and believe that the people that were on the scene did everything that they could do to prevent this horrible outcome that ended up happening despite their best effort. When I was an anesthesiology resident, I rotated through the surgical ICU. Dr. Gary On was one of the trauma surgeons that I was able to work under, to learn from. One of the smartest people I've ever met in my life, and one of the most reasonable people I've ever met. He had this quote that I use very frequently, and I always give credit where credit's due. He would say, "Let's stop for a minute and assume that everyone's reasonable." This was so helpful, when you get that ridiculous consult from some service and you just want to throw your hands up in the air and say, "What are they thinking?" He would say, "Hey, let's stop for a minute and assume everyone's reasonable." More often than not, people don't come to work to be lazy or to not do their job. Yes, it happens. And eventually, you'll kind of figure out who those bad actors are. But first, give them the benefit of the doubt. Assume that they have completed medical school, residency, fellowship training, they're subspecialized. This is their specialty, and they want what's best for the patient, or at the very least, they don't want a bad outcome. That is the basis for the information that they're providing you, and you ask them for their advice. So either you take their advice, or you do whatever it was that you're doing before you ask them for their advice. But definitely stop and think, what is the reason why they're giving me this advice? As clinicians, maybe we've seen a very bad outcome when we've done things one way versus another. A lot of the things that we do, there's evidence-based practice, and then there's the experiential, the anecdotal medicine that we all are guilty of practicing. So I think in summary, these stories are going to continue to come out because every day there are hundreds and thousands of complications that occur in healthcare. It's the nature of the job that we are taking part in. But, as professionals, the very least we can do is we can be a little slower to jump on bandwagons. We can give people, our colleagues, benefit of the doubt. We can try to provide additional information to patients. We can hopefully reassure our patients based upon our breadth of knowledge and the things that we know that happen behind the scenes that cannot be commented on. Times are hard enough as it is. People are getting burnt out already. There's unfortunately bad outcomes that occur all the time. The very least we can do is just extend a little bit of grace to each other in our times of need. But I digress. At this point, we're going to jump back into our conversation that we started last week with Dr. Anthony Douglas. Again, he is a general surgery resident in his third year residency, starting his research block. I had the pleasure of working with him during my critical care fellowship, and we were in the trenches together in the surgical ICU. He would be rounding on the trauma service. I would come in at 5:45, 6 o'clock, and I would come in at 6 in the morning. I'm not gonna lie, I came in at 5:45. I'd come in at 6:05, and he would already be on the unit rounding on his trauma surgery, his trauma service patients. And then I would see him at 7 for turnover, and just an all around great dude, hard worker, man of the people. If he didn't listen to last week's episode, definitely go back and check that out. He kind of shares his story, how he had some influential mentors, people that made a huge impact in his life that helped steer him in the right direction and become the physician that he is today. So we're going to jump back into the rest of the conversation. We're going to talk about mentorship and guidance and interviews and interview etiquette. So without further ado, here we go.
Yeah, for sure. So, and then having the attending mentorship, which, like I said, was ultimately what really made me successful in the application cycle. So I hope, for the listeners, and especially the pre-med listeners and the medical student listeners, that they really take heed to some of the things I said, because ultimately that's really what helped me.
Yeah. And this is obviously on top of getting the grades and passing the exams and all that stuff. I want to dig in though on the mentorship, because I'm not a person that really uses or has a lot of mentors. I'm a bit standoffish, but I know when I need to reach out, and I have several times reached out to mentors like, hey, I need help with this specific thing. But people, there's this misconception of mentorship because I get a lot of emails and I'm like, hey, can you look over my personal statement? Can you answer questions? So everybody is so close now with social media. You can just hit people up. As a pre-med medical student resident, when you're asking for advice, whether it's a stranger on Instagram or it's an actual mentor, and know that those are two completely separate things.
Right.
Number one, you need to have specific questions. The number of emails I get that's like, hey, I'm interested about being a military physician.
Okay.
Okay. And I'm going to hit you back with do you have any specific questions? Because that's where we're going to start this conversation. One, you need to have a specific conversations. When it comes to actual faculty mentorship, everybody as an attending and becoming an attending again, there's a ton of emails flying into inboxes every day. You will get lost in that pile of emails. So once you reach out and try to establish some mentorship, or can you review my CV or whatever, what you need to follow up. And number two, try to schedule actual time with these people. Like you mentioned, talking with the chair and with your program directors, you need to schedule 30 minutes to sit down. You're going to have their more or less undivided attention. They're still thinking about their inbox and reviewing applications and all this other stuff that they have to do.
Right.
But at least you are in their face for 20 minutes, 30 minutes. You're going to be able to talk and start to build that relationship that Anthony just mentioned, where now they know you and they can talk about you in the applications.
Right. I mean, like I said, my relationship with my mentor started by wanting to put in work, right? Like I was looking for research projects, and I told her, I'm looking for research in order to strengthen my application for general surgery residency. And then that relationship developed over time because I could continue to do work with her, and I continued to demonstrate that, I was serious about this, about applying to general surgery residency. And I think that speaks to the other part of what's important about mentorship is it's on you to develop that relationship, right? Because you are one of many students or who all are seeking mentorship and seeking the same things. And the number of, like you said, the number of inboxes we get, the number of emails we get for, help along the way or advice and all these things, like if you don't take the time to be persistent and continue to develop that relationship, then like it'll fall to the wayside. So it's really what you put into it. I'm not saying, be overbearing and email your mentor every day, but I'm saying like staying in contact, updating your mentor, meeting with them, continuing to seek other opportunities with that mentor to do research projects or to get involved in other things. Like these things are up to you to stay persistent. I've had, since being a resident, and even as a medical student, I've had a number of people reach out to me, and some of them, I continue to have a relationship with and continue to help throughout their journey. And then there's others who kind of just like fall to the wayside. And then you like, well, what happened? Like, it's hard for us specifically, when we have so many people reaching out to us, that if you're not staying persistent, it's hard to continue to maintain that relationship if, the effort isn't met on the other end.
Yeah. Especially, in Dr. Douglas' case, he's still a resident. So this boy is putting out 90, 100-hour weeks, 120-hour weeks.
No.
14 days straight.
The ACGMB is listening. It's an 80-hour week for some 80 hours.
They don't overwork them, man. They lived a good life in Chicago. How long was that relationship with your mentor, by the way? It sounds like at least 2 years before you were applying.
I mean, I still have a relationship with her to this day, but I started at my first month of third year. And to this day, I still have a relationship with her. And so, it's been some time now.
So look at where you are, whether you're a medical student or resident, and plan for that like 2 years out, because you need time to cultivate these relationships. When I can only help people so much. I review personal statements, I review CVs, but I can only help so much when I'm just meeting you for the first time or for the second time. But as Anthony did, when you have that longitudinal relationship that you've cultivated, it really means so much more. So you did all that. you interviewed, because that's a big part, right? People are interviewing. Back in my day, we had to book all these interviews. We had to schedule travel. You're already broke and you got to pay for flights, or you got to drive to all these interviews.
Yeah.
But now, TikTok generation, it's as easy as jumping on Zoom.
Hold on, I'm not TikTok. Don't do that. I'm a millennial, my man.
Okay. Right now, you got to jump on Zoom and you interview, and that, everything has its pros and cons. And, I know you wrote a paper actually specifically about, let me pull this out my notes, for Black medical students and virtual interviews. You talked about some of the things to watch out for, or well, I'm sure you can explain it much better than I can, but let's talk about the interview season and how people can set themselves up for success.
Yeah, I think so. A few things, especially in the virtual era, the article we wrote was to give program directors and faculty just a window, a brief view of what it's like to be an African American student interviewing in the virtual era. And we talked about, some of the special considerations that we go through when evaluating programs, but also preparing for the interview, right? And we talked about how a lot of us rely on the residency profile pictures to identify whether we have community or safety in a residency program that we're looking at. We talked about belonging and how it's difficult to assess belonging, especially for, underrepresented minority in medicine, how much you will belong and have community in that program without being there in person. And so to do that virtually takes a lot more effort. And so not only relying on those residency profile pictures, but also based on the brief interactions that we have virtually. So, the 20-minute interview conversations the 3 20-minute interview conversations that you have during the interview is the only time you have to assess whether, you really belong in that environment or not. A lot of the programs during my interview cycle had like the socials the night before. And we talked about even in that paper that sometimes those socials become, the majority of the conversation, a lot of the conversation is surrounded around topics that and conversation that relates to the majority and not really to candidates and people of color, right? They become conversations about
fly fishing.
You might have to delete this part.
What are they talking about? Why lives matter?
It's in the paper, but it's just like it becomes conversations that are hard for us to relate to, right? Like about hiking and about traveling and about things that, for, BIPOC specifically, some conversations that we don't necessarily relate to. And so trying to find your trying to find an ability to relate to people that you might not have much in common with was a struggle, especially when the conversations were surrounded around things that often apply to, Caucasian Americans, right? And so that was another portion of the virtual interview that was kind of made things a little difficult and things that we had to work around. I think when I interviewed, it was around the time George Floyd passed away. And so a lot of residency programs didn't start their DEI committees until after that summer, which I felt like said a lot about the program, right? And so when I was evaluating programs, when I heard those kind of things, it kind of was like a red flag in the back of my mind. Like, wow, DEI wasn't important to you until, this happened. And so these were all things that kind of we dealt with in that, students will continue to deal with, is how to assess your own fit in a program while also trying to be relatable to the people that you're interviewing with and interacting with. For me, we really got into the weeds in this article. We We even talked about appearance for the interview. So,
yeah.
And, I'll be actually interested to ask you about this too, because I've had students come up to me and ask me.
You shaved your beard.
Yeah. I've had students come up to me, ask me about locks in the interview. So I want to hear what you think. But, when I was applying, general surgery is a conservative field, right? Like it's for a long time was dominated by white males, right? And like very much like orthopedic surgery is, and other fields have more of a conservative history. And so I knew that in order to avoid whatever misconceptions or whatever biases that can be applied to me, I tried to make myself appear as though, clean shaven to avoid those type of situations. So I shaved my beard. I was clean shaven for all of interviews, and I was honestly frustrated by it. I didn't want to do it, but ultimately, to change a system, the easiest way is to change it from within and not from the outside. And so, now that I'm a resident, I rock it how I want to, but I did what was necessary. But I'm curious what your thoughts are, because I get the question a lot.
Yeah. Which, I mean, and if you saw Anthony's interview picture, it was, I showed up expecting this little baby face, 17-year-old looking kid. And now homie walks in purple and gold scrubs with the gold chain and the Rick Ross beard. Yeah. So, and we did an episode on this previously about professionalism, quote unquote, and how the term is problematic and can be weaponized.
Yeah.
Personally, I got, the Caesar or fade when I was applying for residency, because to your point, I didn't want any perceptions to inhibit my chance at matching. I didn't have a backup plan. First person in medical school, still was really figuring out, how this whole system worked. And I didn't want anything to keep me from a potential match for residency. That was my number one goal, was to match in residency. So yes, I was clean shaven during interviews. I had a nice, quote unquote, professional Caesar haircut. You type it, no one finds offensive. Everybody just loves and accepts. And to your point, once I established myself in residency, by year 2, I started growing my hair out, and I freeform locked, for better or worse, by the end of residency. In retrospect, maybe I should have got them professionally done. But I freeformed, and then, coming back as a fellow, I continued, I relocked because I was coming out of the Navy and all that. So I have locks and typically have a beard, but I had to do a fit, fit testing.
In the Navy, you can.
No. There's a book. I should post a picture that has like the specific dimensions of the haircut you're supposed to have. Like it can't be thicker than like 3/4 of an inch on the side. And it's now for a year I grew my hair out. That's why if you look at my Instagram, there's some crazy pictures. I had some crazy hair that last year because I was trying to like stay in the rules, but I also wanted to lock. And like as soon as I finished my last shift in the Navy, I went to a loctician and got my hair locked. But yeah, absolutely. And if you ask different people, you're going to get different answers. I don't judge. I don't care if you had face tattoos, gauges in your ear, sleeves, whatever makes you happy. And you'll get different answers from different people. Some people say it's more important that I be accepted the way I am, with locks, with earrings, with whatever. And I 100% support that. Just for me, I was concerned that could negatively impact my chance at matching. So that's my answer.
I think ultimately you have to be willing to accept, that there might be biases applied to you based on your appearance, and and I think ultimately the decision is yours, right? If you, for the black women, if you want to wear your natural hair, for black men, if you want to wear a beard or locks or whatever it is, like that decision is ultimately yours. You just have to be willing ultimately to accept that is a risk. And if that's a risk you want to take, then you take it. I think it's unfortunate that we still live in a climate where we have to think about these things, but it's the reality of being Black in America.
Yeah. Yeah. Well said. Well, now, you got the beard growing out. We'll see what happens for your fellowship interviews. If you see Aunt Douglas with the clean shaven baby face look, it's interview season again, I guess.
I don't know. I don't know if I'm gonna do it again. We'll see. If you interviewed today, would you cut your locks?
Interviewed for
anything?
For the job. So I had locks. I interviewed for my job.
Okay.
So yeah, they're here to stay now. Once I start thinning, and then I
think that's the important point is you got to get there first, right?
Right.
Once you get there, you kind of can do what you will, but get there first,
Absolutely. Let's talk about residency and the time that we have left, because you match full disclosure. These are our own opinions, does not reflect upon those of our employers.
Yeah.
But you matched at residency at the University of Chicago, so close to home. What has your experience been?
Honestly, the University of Chicago has kind of been a hidden gem for me. When I was first, looking at places, being completely transparent and honest, I only really applied to the University of Chicago to have an option close to home, right? Because I've been in the Midwest my whole life. I was ready to get out. I was ready to go far. But my interview with the University of Chicago really swept me off my feet. One part for a number of reasons. One, my interactions with the faculty, I felt like even for the, Caucasian attendings, like the majority of the interviews I had with the faculty, those individuals seemed to be aware and woke, if you want to use that term, about the issues that impact people of color, right? And the reason is because that at the University of Chicago, we serve such a diverse patient population that in some ways you kind of need to understand, if you're serving those patients, what are some of the issues that affect your patients and their outcomes. So even in my conversations alone, and we kind of already talked about it in the virtual interview space, assessing fit, but my interactions and my conversations with those attendings kind of spoke to me, saying and showed me that, okay, these are people that are accustomed to working with underrepresented minorities and also are aware of the issues that affect the patients that the patients of color that they serve. The other part of it, big part of it, was the diversity in the faculty. So, I mentioned that I was interested in trauma and acute care surgery. And when I was looking at residency program, different programs, I noticed that within the trauma department alone, that there were 4 African-American males in the trauma department, which is unheard of, right? Like most of the places I interviewed at, you were lucky to have 2 faculty that were African-American in the Department of Surgery alone. But within the trauma department in and of itself had 4 African-American males. So that stood out to me, seeing Dr. Rogers, Dr. Hampton, Dr. Wilson, and Dr. Williams' picture as a African-American applicant was knocked my socks off. So then I had to start taking it even more seriously, right? And ultimately, my decision was reaffirmed by probably the first couple of weeks of being there, when I learned that 77% of our patient population is African American. And, and not only is our patients African American, but the people who work there, the ancillary staff is diverse. The other residency programs were diverse. The OBGYN department, the EM department.
It's litty.
It is really litty, man. You don't know how much it does for you going to work and walking around and not being the only one and seeing other doctors of color, and then not being weird or abnormal to see a Black physician. You walk at other institutions I've been at before, you walk and and you see somebody of African descent, your last assumption is they're a doctor, right?
Right.
At the University of Chicago, like, it's not, you see someone black walking around a hospital, they could easily be your physician. They could be, right. They could be a healthcare administration. They could be anything, right? And so that in and of itself really like reaffirmed my decision and made me feel like I was at the right place when I chose the University of Chicago. So ultimately, residency is hard, of course, and being black in residency is hard no matter where you're at. But I think going to a place where you feel like you have community is, having community in a residency training program and at the institution that you work for is so invaluable. And you don't know how much it truly does for your own well-being throughout residency.
Yeah.
Because residency is hard no matter what program you're in, but especially if you're going to be there for a long time, you want a place where you feel like you belong and you have resources. So ultimately, I'm very happy with my decision and where I'm at.
Yeah. And full disclosure, as the host of this podcast, I try to focus on more positive things. I don't think I'd ever have people on to bash a residency program. So, that if you hear a program mentioned on the show, it's probably going to be in a positive light because they're doing something right. And it's crazy because I finished residency in 2018 and then I come back 4 years later. And in those 4 years, I left right as the trauma center opened. So the influx of Black faculty members, the residency programs were more diverse when I came back after the 4 years. And I had a great time when I was, here back in 2014 to 2018. And we had our House Staff Diversity Committee and we'd have, 40 plus Black or residents of color. We'd hang out and do stuff. So coming back, I mean, like Anthony said, it's invaluable. I knew when I was in the surgical ICU, I would come to morning trauma sign out and I see Anthony and Jelani, and we'd be sitting there, making faces. Well, at first we were wearing masks.
Trying to get us in trouble, man.
Yeah, man. I'd be a little zesty and I was post 24.
That was that. I got a job already glow. That's what that was.
But coming from Howard, University of Chicago it has so much to offer, and Anthony did a great job of summing that up. As we close, a big controversy always comes up on med Twitter, but 24-hour shifts versus 12-hour shifts. So I'm curious about your thoughts.
That's interesting. So I actually prefer 12-hour shifts. I'll be honest. We do a lot of 24s as general surgery residents, but I think 24-hour shifts is unnatural. Is the easiest way for me to put it. I think it's not safe for patients and it's not safe for doctors as well. And some of my old school general surgery co-residents and some buddies from other programs will probably get on me for saying this, but I do think it's unnatural and it's unsafe. And I can think of multiple times being on post 24 and nearly being delirious, rounding, and it's exhausting. And I just think it's not. I think in this day and age in 2023, there's a more efficient way we can think of, and a more efficient and a more safe way we can think about caring for patients. And ultimately, I'm definitely a fan of 12-hour shifts. I think is safer for patients, and I think you get more out of. I think the downside and what people say negative about the 12-hour versus 24 is that, being in the hospital, you innately learn more, right? Because you see more things in a 24-hour shift. You are involved in more cases, and there's just like, the more you're in the hospital, the more you learn, right?
Yeah.
But ultimately, I think there's a VMAX, there's a plateau to that. And I think that plateau is definitely reached during the 24-hour shift, right? Like I've been in the hospital when I've been exhausted during the 24-hour shift, and I just don't think it adds much value to my education nor to, my care for patients. So I would definitely say if there was one thing, I'm all for the 80-hour work week, and and I have no complaints about how many hours we work. But if I did change one thing, it would be getting rid of the 24-hour shift.
Oh, interesting. Yeah. It's good hearing your thoughts.
Yeah.
The TikTok generation.
And not TikTok, man.
Oh, man.
You having me, though, man. Thank you.
Well, Dr. Douglas, thank you so much for coming on the podcast. It's really been inspiring to me to hear your story. I mean, we worked together for a year, and I didn't know a lot of the things that you discussed. So it's truly been a pleasure having you on and hearing more about your life.
Appreciate you having me, Dr. Bradley.
Good luck. You're starting, your quest and research. What are you going to be researching, by the way?
I'm doing some advocacy related stuff. So I'm trying to do something a little different with my research time. And instead of doing kind of a traditional bench or outcomes research, I'm trying to do things related to, surgical advocacy. And because I'm interested in trauma, I'm going to do things related to violence prevention. So thinking about interventions to help prevent community and urban violence, and researching those type of interventions, and trying to truly have an impact on the Southside community in terms of that. So whatever research that allow me to I'm trying to essentially build a curriculum for residents who are interested in doing advocacy work, whether that's in trauma or whether that's in breast cancer disparities or whatever you name it, a curriculum that allows them to start thinking about building a career and being a surgical activist. So that's kind of what I'll spend my time doing.
Yeah. Excited to see how that progresses over the next couple of years. Thanks for coming on the show. Thank you for the work you're doing on the South Side of Chicago. The community is much better for you being there and working and providing the amazing care that you provide.
Appreciate you, man. Thank you.
Awesome. Well, thanks for tuning in to Black Doctors Podcast. We're here every Monday because representation matters.
Yeah.
If you've been listening to the show and haven't already, definitely follow us on social media. Go to iTunes or Spotify, wherever you get your podcast. Leave a ranking and a comment and share with your friends.